seen the prelims, so most of the things remain the same. The marking pattern is 4 marks max for the speaking skills, and 4 marks for the content, and 1 for the questions that you answer, either a 0, 0.5 or 1. And to finish within 4 minutes, it's one mark. So that is something the easiest to get. And we have decided to have we have got the lots of the sequence. So the first candidate will present in this sequence, and the same sequence will continue for the second candidate. Both will not be presenting one after the other. Okay, so that's how it is.
So what we are going to do is 1 to 6 we have decided a lottery, right? So one from each team will present in that sequence. Okay, then again once that is over, the second round will start.
Same sequence will continue for the second round.
So the mentor will decide who is going to come first from each team. So first team is KF ring, but due to some medical urgency, that team have left. One of the mentee. So they are not going to present. Only one mentee is there. You are there, right?
Mentee 1, mentee 2, right?
Okay. So no. There is only one mentee. How can she present? We need 2 now. Anywhere score will be half. We'll give you a certificate. Don't worry.
No, maybe when we are collating the marks, you can present.
Yes.
So in the
Your
injury
party
time.
can present if you are prepared.
You are prepared or
She
not?
hasn't prepared.
But it's nice of you to actually physically present here. Thank you so much.
So the second team is Perceptor Queens. So who is going to present? Yeah, please ask them to upload your PPT and come to the stage.
KF ring sometimes disappears. Rare conditions.
So who is presenting, Radhika or Nikita? You have to upload there. Don't come with your laptop, or else we'll go to the next team.
Strictly no laptops, please. Okay. Yesterday we made an exception, but no laptops.
The second person can present.
The second person,
Radhika,
Radhika, Nikita. None of you have uploaded your PPT. Please come forward now. Whoever has uploaded, they can present. The other person can present later.
This
She will be presenting the new topic or older one? New one. You can help now. So which topic you have chosen? We had given you 2 choices. Mike.
yeah, Preceptor Queen.
You are
She's
from
Dr.
the Preceptor
Radhika.
Queens, right? And you are Radhika.
And please call your mentor. No, it doesn't look good. Mentors are not there in finale.
Yes.
Just inform your mentors. If mentors are not there, then we'll not consider for awards. Sir, I think you can keep some marks for mentor also.
mentor को भी question पूछेंगे. Now that we have more time.
Timer 4 minutes. 1 beep after 3 minutes. Okay, to all speaker. 1 beep after 4 minutes. After 3 minutes, 1 beep. Total time is 4 minutes. You can start.
So good morning, students. So many often you see that patients come to your OPD who demand spectacle independence, widespread use of smartphones. They have widespread use of smartphones, tablets, gadgets, hence the demand for intermediate vision. There are concerns regarding wavefront aberrations, dysphotopsia, and minimizing PCO. So we need to match patient to technology and technology to the patient. Hence I am here to discuss IOL materials, what's new. Keeping up with the IOLs, what were the conventional IOLs we used? There was PMMA, which used a rigid material. We required a large incision. It had a low inflammatory response, but with a high PCO rate. Next were the silicone IOLs. They were foldable. They required a smaller incision. They had low inflammation, but the tissue injury risk during expansion was present. In acrylic IOLs, hydrophilic had low inflammation but a high PCO rate, and hydrophobic had a low PCO rate but a higher inflammation. So coming to the new optic materials, they can be injectable IOLs, shape memory IOLs, adjustable IOLs. And then there are surface modifications which we have never heard of. The anti-inflammation properties, anti-posterior capsular opacification, anti-endophthalmitis, and carrying monitor sensors. So what's new which I'm going to talk about today? I'll be talking about the structural designs, materials, which is best for a specific patient, their advantages and side effects if any. So first of all is the material inserted through a smaller incision. There are deformable PDMS lenses which are filled with a transparent liquid and they can be inserted through a smaller incision. Next are the shape memory intraocular lens. Like our memory, these also have a memory in them. When after they get inserted, they will expand to their shape and accommodate accordingly. Next are the intraocular lens surface modification materials. There are materials to reduce the inflammation, materials to prevent posterior capsular opacification like PPEGMA, drug loading modifications like CSA and paclitaxel, photodynamic coating modifications like ICG and PLGA to prevent PCO, and there are antibacterial surface modifications like vancomycin. Next, the very important slide is the light adjustable lenses. So these are non-invasive post-surgical adjustments using UV light and vision tests to customize and correct refractive errors post-operatively. So they can correct for astigmatism, both near and far vision. We can see in the image that after the light, there is a photosensitive silicon macromer. So after the light, it gets unpolymerized and it diffuses to the central region, causing swelling and change in the refractive power of the lens. Next are the accommodating IOLs. They are more flexible, using the eye ciliary muscle contractions to change the lens shape and the refractive power of the lens. These are the injectable IOLs in which we can inject directly a silicon polymer and it will expand and it will give the required refractive correction for the patient. Next are the electronic autofocal intraocular lenses, the AF-IOL. The autofocus system will send signals that trigger the micropumps to alter the curvature of the optical membrane through the liquid. So the carry-home message is patient selection is most important. Not all types of IOL are suitable for all patients. Selection is the key and repeatability is the crux. Understanding the potential benefits and complications of each kind of intraocular lens is critical. So though the armamentarium is very vast, but our choice should be judicious. Thank you.
Well presented, Dr. Radhika. See, all such talks will be like a matrix movie. You'll begin so much of things from the internet, but in the next 5 years, what is the big change that you see from what we are doing today? Because that is what we are interested in. So, a lot of things that you told may not really happen, but what in the next 5 years, what will be the change?
So I think we are trying to make we have not reached any ideal perfect IOL, but we are trying to make such that it is correcting everything what the patient requires according to the patient's needs, his occupation, and what are his or her hobbies. So according to that, to remove any chromatic aberrations for both accommodative for both near and far distance vision as well as intermediate distance vision, we are trying to include everything and to make a perfect IOL.
I think the next biggest low hanging fruit is the aberration, basically the higher order, not chromatic, the higher order aberrations customized to the patient's eye. Just like we customize the power of the eyeball to the eye,
Yes, sir.
like each patient requires a different power, we can also take care of the aberrations part of it. Okay, well, I think you can clap for her.
So next team is team Moria's Master Blaster, and the topic they have chosen is AI in ophthalmology, right? Dr. Harnaj. Some printing error. The team is Farnaj and Ruju.
One second, sir. It's not playing.
Is it video?
It's not. Yeah, it's a video.
It's a video.
Not playing. It's not playing.
Then Ruju, you can present. Let Ruju present. She can sort it out.
Okay.
रुजू का टॉक दे दो, तब तक ये शॉर्ट करो क्या हो रहा है. So Ruju, what are you presenting?
I'll be presenting on OSSN.
Okay, yesterday's talk. Good. Good. Go ahead. रुजू का टॉक पहले दे दो, फिर ये शॉर्ट करो. Next is atropa belladonna. Please ready with your PPT and check if it is running or not, right?
So one tip is to please don't look at your monitor. Please look into the eyes of the audience. Have an eye contact. That will make it a better impression.
It's not.
Okay, okay. Start. 4. 4.
Good morning, class. So, what are we learning today? It's not moving. So, what are we learning today? Students will try to cover what is OSSN, why is it important to know about OSSN, how to diagnose a case of OSSN, and how to manage a case of OSSN, and finally, quick revision key points. So, what is OSSN? As we all know, ocular surface squamous neoplasia is a broad entity that comprises spectrum of squamous neoplasms including pre-invasive lesions or intraepithelial neoplasms and invasive neoplasms such as squamous cell carcinoma and more aggressive variant such as mucoepidermoid carcinoma. Why is it important to know about OSSN? Do you know that out of total oculoorbital tumors, OSSN account for nearly 4 to 29% and it is the most common conjunctival tumor in Asian Indians? So, predisposing factors could be infections such as HPV, HIV, hepatitis B, hepatitis C and other non-infectious factors such as UVB light and xeroderma pigmentosa. How do we classify OSSN? Based on location, it can be classified as conjunctival, corneal or corneoconjunctival. Based on its morphology, it can be further classified as papillomatous, leukoplakic, gelatinous, nodular, diffuse or pigmented. How do we diagnose a case of OSSN? Interpalpebral location near limbus, surface keratin, rose Bengal stain positivity, feeder vessels, intrinsic vascularity are 4 key clinical features to diagnose a case of OSSN. On ASOCT, OSSN appears as a superficial hyperreflective layer with an abrupt ending. It can further help to define depth of the lesion. In a case of OSSN with orbital involvement, MRI helps to play as a vital role in planning orbital exenteration. To diagnose a case of OSSN, it is also important to differentiate it from its close clinical mimics such as pterygium pinguicula, bitoid spots, papilloma, pyogenic granuloma, and amelanotic melanoma. Let's understand about the available management options. Medical management can be tried in form of MMC, 5FU or interferon. But don't you think this is a very busy slide? Here is your teacher and I'll be making it simpler for you. In a case like this where tumor is flat but extensive, involves 5 clock hours without any scleral invasion, what will be your ideal management option? We'll choose topical interferon alpha 2B for this case to avoid any limbal stem cell deficiency. But in a case like this where tumor is small, localized and elevated, what do? Simple surgical excision, right? And how will you manage this case with a large nodular component which also has a scleral fixity? Well, we can very well manage it by a simple excision biopsy followed by a plaque brachytherapy. So now how we do excision biopsy? So what we do is, we simply mark the 4 mm clinically clear margin from the tumor itself. After an alcohol-assisted keratoepitheliectomy, we try to dissect the tumor off its corneal base with the help of crescent knife. We excise the tumor, do the base cryotherapy at the residual conjunctival edge. After dissection of the tumor, we do residual cryotherapy at the conjunctival edge, followed by a surface reconstruction with help of AMG and glue. So, to conclude, in a case of OSSN can be easily managed by this simple key points: ocular examination, thorough systemic evaluation including serology, careful surgical excision can give gratifying outcomes, and always check for nodes to see and rule out loco-regional spread. Thank you.
Thank you. Question from judges. In the meantime, Belladonna team, please prepare your PPT.
So, Ruzu, if you have one investigation available with you to help you conclusively diagnose, of course, clinically you have a lot of clues, clinically you already mentioned. So now you have to go to investigation. So which one would you do?
I like to do ASOCT to rule out the depth of the lesion, to plan my further surgical options, whether it will require plaque brachytherapy or we can simply proceed with excision biopsy.
So what about
Impression cytology is also a good option, but only can be used in case of doubt. But if we are thorough with our clinical knowledge, and it might not be required in all the cases.
Thank you.
Have a role impression cytology?
It is not 100% sensitive. Sensitivity is around 80 to 90% for impression cytology. So in case of
because
doubt,
of its ease, should it be still employed?
yes, sir.
No, yes, I mean, you're not very, you're not very, little doubtful about it. Don't you think it's easier than any other technique?
It is easier, but ultimately we'll have to excise the lesion, whether it's a papilloma or papillomatous OSSN. Ultimately, treatment will be excision biopsy only. So better to go ahead with full excision biopsy followed by histopathological evaluation.
Okay. Thank you.
Thank you. So, Belladonna, Dr. Avneet Kaur. So, Dr. Avneet, what are you presenting?
Sir, I'm presenting my presentation on tests of stereopsis.
Okay. So, previous one.
And, position the mic properly.
Good morning, everybody. I'm going to present on my topic on tests of stereopsis. So, a horopter is a collection of points at a specific area on which any object that lies is seen singly. And if an object lies in front or behind the horopter, it can be seen as double, except when it lies in the Panam's area of fusional reserve. For example, an object A, it subtends a certain angle A on each eye, and an object B, that is the tree in this, subtends an angle B on both eyes. So in stereopsis, in test of stereopsis, we're measuring the difference between these angles, that is the angle C. So stereopsis occurs when horizontally disparate retinal elements are stimulated simultaneously. Grades of binocular vision on synoptophore: simultaneous perception, fusion, and stereopsis. Simultaneous perception is when two dissimilar objects are seen singly. And fusion means when two slightly dissimilar objects are seen as singly. And stereopsis is when two similar objects are seen from different angles and depth perception is appreciated. Stereopsis is measured in seconds of arc. That is, 1 degree is equal to 60 minutes of arc, 1 minute is equal to 60 seconds. Random dot tests like TNO Frisbee provide the most definitive evidence of high-grade binocular single vision. When there is weak or there is a presence of ARC, contour-based tests like TITMIS may provide more reliable information. So tests for stereopsis for near are 3D Polaroid vectograph, for example TITMIS, and random dot tests like TNO, Lang, and Frisbee. So TITMIS test consists of a 3-dimensional polarized vectograph which is seen through a polarized spectacles and at 40 centimeters. So the wings will give, if the patient can appreciate the wings as in a three-dimensional state, then the stereo acuity is thought to be, is said to be 3,552 seconds of arc. Similarly, the circles from 1 to 9, they give a stereo acuity from 800 seconds to 40 seconds. And the animals, the rows A, B and C, they can measure the stereopsis from 400 seconds to 100 seconds. TNO test, they consist of 7 plates. First 3 plates are for gross stereopsis and the other plates are for 480 to 15 seconds of arc. It is done at 40 centimeters and red-green glasses are used to view the randomly distributed red and green dots, which are displaced horizontally in relation to paired dots of the other colors so that they have a different retinal disparity. Control shapes are visible without the spectacles. Then there is a Frisbee test. 3 transparent plastic plates of varying thickness are present in Frisbee test. 4 squares of small randomly distributed shapes. One of the squares contains a hidden circle in which the random shapes are printed on the reverse of the plate. It does not require special spectacles because disparity is created by the thickness of the plate. So these are the octave based for different plates of thickness and for different working distance. There is a then there is Lang test 1 and Lang test 2. It does not require any special spectacles. Star is monocularly visible but provides a stereoscopic effect. A star, moon, car and elephant are seen alternately by each eye through built-in cylindrical lens elements, and displacement of the dots create disparity of 1200 to 200 seconds. Random dot, now comes this test of stereopsis for distance. There is a distance random dot stereo test which is done at a distance of 3 meters. And the answer key is also provided at the back of the distance stereo test. And there is a pediatric spectacles and an adult spectacles. There is a Frisbee-Davis 2 test in which markings on the rods enable the disparity of the target with respect to other shapes to be set in the range. Lang to pencil test is a crude test for gross stereopsis, measures 3000 to 5000 seconds of arc. So this is a picture which can be viewed with the red-green glasses that I've kept at your table. You can use them to view this picture.
But your time is up.
I think your time is up, Abni.
It is up, so.
Next class.
Ma'am, sir, I've kept a red-green glasses for you on the table. If you can use that.
Achha, that was for judges, okay? You should
Yes, sir.
Ask question wearing this.
Sir,
and saw that image, see that image.
can you put on that slide, please?
Have you finished or not?
Sir, I finished. I was just trying to show you the
Okay.
picture at the end.
Was this your new topic given yesterday?
No, sir, it was the old one.
Then very surprising. It lacks a lot of depth. Your talk on depth perception lacks some depth. Anyway, there are 2 questions I'll ask you. Number 1, you said 30, 60 seconds of an arc. Let's say I'm an undergraduate student. You please explain simple English. What do you mean by this 30 seconds of an arc?
30 seconds of an arc, sir.
What does it mean? If I have 30 seconds and you have 60 seconds, what is the difference? What is that seconds of an arc? How do you actually explain it to me?
Sir, it is the difference between the two disparate images. That is the angle we measure for the testing of the stereopsis. So the angle is, if 1 degree is equal to 60 minutes, 60 minutes is 1 minute is equal to 60 seconds. So the lower the seconds of the arc, the better the stereopsis would be.
So that is the difference between the visual angle subtended by the 2 points which are different in space.
Yes, sir.
So if more is the angle, then probably your stereopsis is less
Yes,
is the angle. That's what you mean.
Yes.
Okay. The second question is, can we use this stereopsis test? Like for example, we go to kids like kindergarten where children are, okay, where you can't use the lens chart. Can you use this because a one-stop shop for your visual acuity in both eyes, amblyopia, suppression, all points can be picked up by a stereo acuity test. So can we use stereo acuity test, let's say for a 3-year-old kids, so that it can be one thing for all the things that you want to check, which is so difficult otherwise conventionally?
Sir,
Then why you are not using it?
Sir, in this test we can use the Titmus fly test. The wings are easy to appreciate for preschool children.
I'm not talking
even
about
3 years old.
checking stereopsis. I'm saying, can checking stereopsis be extrapolated to the rest of the visual examination that you want to do in this kid, which is preliterate or which we can't use the charts?
So stereopsis is a marker. Having a good stereopsis is a marker of having good visual acuity in
In
patients.
both eyes?
Um, doesn't have to be, sir. If there is an isometropia, then the stereopsis would be affected.
Okay, thank you.
So next we have the AIMS Patna team, and Dr. Aditya is going to present on management of DMD.
So, good morning class. I'm going to teach about management of post-cataract surgery DMDs today. So imagine you've finally started with phaco, and it has been an uneventful surgery. The IOL is well placed in the back, and we are expecting a good visual outcome for the patient the next day. But this is the kind of picture that we see, and this is the kind of reaction that it often elicits. So why bother to know about DMDs? Because they are not so uncommon, and they have an incidence of up to 0.5% in phacos, even higher in ECC, and on gonioscopic examination, up to 40% of the cataract cases, they might have some sort of DMD. Early management is simple and efficient, and when missed, they may lead to permanent scarring and edema, and the patient may have to undergo endothelial keratoplasty. So the causes can be grouped under subject, surgery, and surgeon. If the patient has a hard cataract, there are presence of corneal scars, there is a dense arcus, or the patient has some endothelial dystrophy, ectatic disorder, then he may be predisposed to having a DMD. Or if during surgery we use blunt instruments, the phaco time exceeds 60 seconds, there is a shallow AC, or while implanting the IOL or injecting drugs at the interface, we might cause DMD. And the most important or the most widely known cause is an inexperienced surgeon who is having a bad day. So what is the natural course? Smaller DMDs that are smaller than 100 microns, they usually self-resolve. But if the larger ones, they need our intervention. So what happened during this case, it was missed intraoperatively, DM detachment. So during the surgery, DMDs, they may be seen as a thin, transparent, fluttering membrane, and they may be confused with capsule or remnant of cortex, and intraop ASOCT can be done for confirming the diagnosis. And we should never do, as my assistant, who is a very bright person, he said, and I quote, "Boss, ये जो capsule remnant है, इसको forceps से निकाल लीजिए." So we should never attempt such things during surgery. We can just press the posterior lip of the wound, and if it is a remnant of the cortex or capsule, it will come out. So we should suspect DMDs if the patient has a lot of stromal edema on the post-op day 1, or if there is non-resolving stromal edema even after 3 to 4 weeks. Or it can be picked up easily on slit lamp examination, but however, if there is severe edema, ASOCT should be done, and it also helps in localizing the size, extent, location, configuration, and also the follow-up of DMDs. The configurations described on ASOCT are planar, scrolled, tractional when there is no tear. So the management begins when we start planning the patient for surgery. And remember, fortune favors the brave, but it listens to the wise. So if we see that the patient might be predisposed for DMDs, we should plan for a superior incision. The gold standard is pneumatic desmetopexy. It is done with a 26 or 30 gauge needle. The air is injected from a site that is away from the DMD. It might cause intracameral gases, may cause pupillary block or raised intraocular pressure. So these are some other techniques that have been described, such as giving ab interno relaxing desmetotomy, drainage of supradesmetic fluids. So knowing the height, extent, length, and pupillary involvement helps in managing DMDs. If it is a small peripheral, less than 100 micron size of DMD, we can manage it medically. If it is larger and it is superior, we can give intracameral air. If it is superior but it is non-planar or scrolled, we give intracameral SF6 or C3 effect. Inferior DMDs are managed with intracameral SF6 and C3 effect. If they do not resolve, we can repeat the procedure, or we can advise endothelial keratoplasty. Thank you.
Thank you.
Thank you, Aditya. Good, nice presentation. So you said that planning starts before, and you should look for cases which are at risk. So what are the risk factors when you anticipate that you might have a DMD, we have to be very careful.
Ma'am, so if the patient has already undergone surgery in one eye and we see that there are
Tell
old
me
scars,
1, 2, 3, 4 conditions which are more predisposed for DMD, for intraoperative DMD during cataract surgery.
ma'am, FECD, keratoconus, if there is a hard cataract or the patient has corneal scars due to previous infection.
I don't agree about keratoconus. Okay, thank you.
Next, we have team CFS Retina. Dr. Sweta Singh is going to present about newer anti-VEGFs, right?
Good morning, class. I'll be talking about neo anti-VEGFs. So before moving, let us discuss what we'll be studying in this class. What are VEGFs? What are anti-VEGFs? Why anti-VEGFs? What are newer anti-VEGFs? And why newer anti-VEGFs? So many questions. So it was long back in 1948 that Michelson speculated the existence of factor X in the retina, which controlled the growth and development of retinal neovascularization. In 1994, it was identified as VEGF. So there was a need to fight this VEGF with anti-VEGFs. They are the antibodies against VEGF proteins, which are injected through pars plana route, and they are used in the management of retinal diseases with exudation or neovascularization, like neovascular AMD, diabetic macular edema secondary to RVOs, ROP, and many more. So why anti-VEGFs? Earlier, the standard of care were lasers. They delayed the risk of severe vision loss, but anti-VEGFs transform the management of retinal diseases. It not only maintains vision, but also improves them. So this is a video just depicting how we inject anti-VEGF into the eye. Now, about the anti-VEGFs, there were some proteins which started with the pegaptinib, which was earlier FDA approved in 2004, sorry. Then came bevacizumab. It was never approved by FDA. It was only approved for colorectal cancer, but it has been using as off-label. Then came ranibizumab. It was approved in 2006. Then came aflibercept. It was approved in 2011. And it was a protocol T which proved that it was safe and efficacious and superior to ranibizumab and bevacizumab. Now, why was the need of newer anti-VEGFs when we had already so many anti-VEGFs? Patient had to be given repetitive monthly injection. There was cost of the drug, which was taxing. Consultation charges and every follow-up visit was also very difficult for the patient. So there was need for longer duration of action with improved durability. So came the newer anti-VEGFs. The first one was brolucizumab, which was FDA approved in 2029. It had the unmatched drying effect. Then came faricimab. It was approved in 2022. It had the promises of longer duration of action. It is the newer anti-VEGF. And the aflibercept 8 mg or the Eylea HD, which was approved last year, 2023. It claims of longer duration of action, but it is not available in India. So if we summarize all the anti-VEGFs, we remember 1, 2, 3, and 4 rule that says that ranibizumab is effective for 1 month, aflibercept for 2 months, brolucizumab for 3 months, and faricimab for 4 months. Now, these effectivity of all the anti-VEGFs, it is only taking place after we give an initial loading dose of 3 to 5 injections. Out of all these anti-VEGFs in the market, aflibercept is still the preferred anti-VEGFs which has to be used. Now, something about the biosimilars. They are the molecules which are similar to existing biologic medications. They have the comparable efficacy, safety, and duration. Their production is cost effective. That's why they have been worldwide accepted. So, out of the many biosimilars, the first one was Razumab, which was introduced in India. The FDA approved ones are Biovis and Cimerli. About the anti-VEGFs under development, we have sozinibercept, which is used as a adjunct to the standard of care anti-VEGFs, and bevacizumab near-one, which according to NORS trials is still under development. It is only approved by European Medical Agency. Thank you.
Thank you.
Two things. You would ask me a basic question like, these anti-VEGFs block the VEGF receptor or block the VEGF?
block the VEGF receptors, sir. The receptors,
All of them?
not all of them. Basically, the VEGF A and
No, you mean like even ILIA blocks the VEGF receptors?
sir, it acts as a decoy protein. It acts like a decoy protein means it combines with the
ILIA
VEGF
blocks the
receptors.
VEGF receptors or the VEGF?
So VEGF receptors.
No, ILIA is called the VEGF trap. So why should it block the receptor? It blocks the VEGF itself, no? You're not very sure? Okay. So what are the ones systemic, I should say the contraindication that before giving any anti-VEGF, what do you really look into the patient's body, the system?
So basically we ask about the history of stroke or any myocardial events. If it is within 3 months, we try to avoid it. And
Why? What will happen? What exactly is the mechanism?
so as it causes, it blocks the VEGF receptor, it can precipitate any myocardial infarction
How?
or stroke.
You give such small quantity in the eye, but how does it actually precipitate a myocardial infarction in a recent MI? Okay, thank you.
Next presenter is from the Perceptor Queens, Nikita.
Good morning, everybody. The topic for my topic is management of congenital ptosis. I'll take you through clinical evaluation and diagnosis with grading, management, of course, surgical techniques and visual rehabilitation and follow-up. So, when a patient comes to your OPD, you have to ask about the onset and progression with birth history, diurnal variation. Old photographs is very important to assess. Also, look for head posture if there is any head chin lift or head tilt, frontal furrowing, lid crease present or faint, and lagophthalmos, check for Bell's phenomena along with extraocular movements and corneal sensations. Tear function is also very important along with strabismus assessment and slit lamp and fundus examination. So, along with this, the ptosis evaluation, we need to know the degree of severity, complicating factors. So, visual acuity should be done with cycloplegic refraction. Along with that, MRD 1 and 2, palpebral fissure height, margin crease distance is very important to assess. Look for levator excursion. It may range from excellent to poor. Then we come to management. How do we manage? There are two things, amblyopia and visual access. If there is clear visual access and no risk of amblyopia, then of course the patient, we can wait and watch, and the patient has to be followed every 3 to 6 months. But if there is ptosis interfering with the visual access, abnormal head posture and risk of amblyopia, surgical intervention is must. So let us go into the surgical intervention. Surgical intervention based on degree of ptosis, which is based on MRD1 values, may range from mild to moderate to severe. Then go to look for levator excursion. If the levator excursion is very good and excellent, that is more than 10, Fasanella cervid can be done. If it is good to fair, that is more than 5, levator resection. Then in most of the cases of congenital ptosis, there is we do frontalis sling where there is poor levator function. Let us go to the surgeries one by one. But before doing, with surgical correction, what we aim? We aim bilateral symmetry, eyelid position, minimal of lagophthalmos and corneal exposure. So keep in mind, if there is any of the condition like extraocular abnormality, poor Bell's, the patient can land up in exposure keratopathy. The most common surgery is frontalis sling, where indicated in blepharophimosis, oculomotor palsy, severe ptosis with poor levator function and Marcus gun. Sling materials varies. Sling materials are used, silicone band being the most common one, where eyelids are suspended directly from the frontalis muscle. These are the steps that we can see. Now moving on to the second one, it is levator resection performed with good levator function. For every 1 mm of ptosis, 3 mm of levator LPS is resected. There are two approaches, Everbush and Blaskowitz. One is external and other is transconjunctival, as we can see in the picture. So the third one is Fasanella cervid surgery, indicated in mild ptosis with good levator function, as we saw earlier, and in Horner syndrome. There is tarsoconjunctival resection done in this surgery, which involves excision of Mueller's muscle, and maximum elevation achieved is 2 to 3 mm. And vertical tarsal height should be noted, which is must. So post-operative follow-up, always, if you're going through a surgery, post-operative follow-up is must. Follow-up every 6 months. Ask the parents to take sequential photographs, as surgical intervention and reinforcement may be required in cases of sling loosening. So the take-home message we take is clinical evaluation to assess severity grading for this management of ptosis largely depends on this. Appropriate management techniques should be adopted for specific grades for optical outcome. And amblyopia management and visual rehabilitation is very crucial. And of course, when there is any bacha involved, educating parents is must. So here I complete my topic. Thank you, students, and thank you. So if a patient now comes to you with congenital ptosis in the OPD, you know what to do. And if not, you can contact me.
Thank you, Nikita. I mean, your topic is ptosis or congenital ptosis?
Congenital ptosis.
Congenital, okay. So, let's say you get a patient of, let's say, 15 years. The history is not really known, whether a ptosis is there from childhood or not. Only looking at the examination. Let's say, for example, this child has severe ptosis, but the LPS action is pretty good, okay, and there's no Marcus gun phenomenon. So what is this situation? What is the diagnosis? The history not known to us, whether it is congenital or acquired, we don't know. So how do we actually gather it from the clinical findings?
Sir, there are 3 things that we should look if we are suspecting congenital ptosis. Like we ask the patient, we see the lid crease if it is faint to absent. In downward gaze, there is a lid lag in downward gaze which has to be seen. So if these 2 are present.
Why lid lag? Why it is not in an acquired ptosis?
Sir, because in congenital ptosis there is dystrophic levator LPS
very
action.
good.
So it won't relax even on closing.
Okay, so a severe ptosis with a good LPS action suggests what? Congenital or acquired?
So severe ptosis with good levator function, it is not as commonly seen in congenital ptosis, but there are cases where we will ask for diurnal variation also. Like it is rare, but myasthenia gravis in congenital patient is has been reported. Yes.
Okay, so if that is the case, usually it suggests a acquired ptosis, aponeurotic ptosis. Okay, thank you so much.
Thank you.
Our next presenter is from Maurya's Master Blaster, Dr. Farnaz.
Sorry for the technical glitch. So let's start. Hey ChatGPT, can you help me with this? Is ChatGPT and generative AI your best friend these days? AI everywhere. So face recognition, fingerprint, iris scan to research paper writing. But why am I here for as a teacher today? Let's dig into it. Okay, so this is the population of India, and this is the disease burden we face as ophthalmologists. And how many of us are there? 15 per million population according to a data collected in December 2023. And if you increase it, when you see urban and rural disparity, it is higher. So just with training more doctors and conducting eye camps, do you think it's possible to bridge this gap? No. We need something, and that's AI, especially deep learning, which requires almost nil human interaction. So how does this work? Just like the human brain and neural connections with CNS and PNS, DL has multiple layers. Say for example, if you show with breed of dogs, Golden Retriever, Pug and Pomeranian with annotations, it reads the characteristics and develops its own understanding and comes to a conclusion, and it will tell you how each one differs from the other. So ophthalmology, as we rely heavily on imaging, deep learning divides the fundus images as referable and non-referable depending upon the grading of diabetic retinopathy. It is also useful in ARMD and ROP screening. The data is broken down into pixels and the disease is recognized. So, can we laser the retina with just a command from the AI according to the area? Yes, we can. In glaucoma, for early screening, diagnosis, progression monitoring, to analyze the visual fields, help maintain patients, the drug schedule and IOP charts, and just with these annotated images, we can identify the glaucomatous damage, fasten the workup, and manage very easily and quickly as well. In cataract, preoperatively, cataract grading automatically with just 38 points as marked, and IOL super formula has also been developed. And intra-op surgical workflow analysis to identify the stages of procedure, guidance regarding which instrument use, and we have developed almost a robotic scrub nurse just for the surgeon wearing an eye tracker so that there is minimal hand movements in the field. Then, in cornea, preclinical detection of keratoconus, refractive surgeries, early detection with just screening and images. In squint, detection and management of amblyopia with various softwares. Squint surgeries calculation. In ocular oncology, app-based screening for retinoblastoma. Anticipate the course of the periocular reconstruction. Predict the disease outcome. OSSN with multi-spectral imaging. And how is it helpful for residents? So here is an augmented reality eye model. You don't need a VR glass as well. So especially as a beginner, what's the angle, what's the anatomy? So this will give you all the details regarding like what all you don't know as a beginner. New features are also being added as well. So there are many AI tools that can also help with dissertation, presentations, but the essence of human creativity and standing out in a common forum. And when it comes to patient care, the human touch, all this makes the difference. So when this was initiated, there was a scare. There was an arm wrestling between doctors and AI. But these algorithms are dependent on highly curated data, and sometimes they miss the real life scenarios. In reality, AI and doctors' brains and the knowledge we have always should work together for a better healthcare and humanity. These are the QR codes for the augmented reality models. We are not there here still with something like Jarvis. I asked ChatGPT if it could help me with finding out how many students are sleeping in the class. It told me to just look at the crowd, know the signs and all. We are not there still here, but we'll be soon there. But at least for doctors like us, AI is an adjunct, and that's why I'm still here as your professor. Thanks a lot.
Very good topic you chose. That was a smart move. So my question is that tell me some of the devices that we have currently, and I have no financial interest in them, in which we're using AI-based detection.
Yes, ma'am. Currently, most widely it is used in diabetic retinopathy. We have some of the softwares available as IDX, iArt, and also Google AI Healthcare is also
Any
used.
other devices that you have that you can use in the clinic or in the field?
Remedio is also useful, ma'am. Slit lamp imaging. It's useful. Remedio is a non-Madriatic.
Audience, please don't answer the questions because they're getting marked for it. So I don't understand why it was answered by the audience.
So, yes, ma'am. It helps in slit lamp imaging and also non-Madriatic.
So he said Remedio. So can you mention what specifically on Remedio devices that you have? Do you know what it is? It's exactly the summary of your talk.
Yes, ma'am. So it's a it's used as a non-Madriatic fundus camera. Okay. So it can be mounted on a slit lamp also.
That's fine. So what does it detect for you?
It detects the images of the posterior pole. So it can be helpful with glaucoma and also early stages of ARMT and late stages as well.
So okay, fine. So
okay, I am interested in the cataract surgery. So you said you had a very fleeting remark on the cataract surgery where you should have dwelt more time. How does it actually help in the IOL formula, you said? What exactly is the IOL formula in which AI is incorporated?
So when we feed AI with the already pre-existing formulae like Holiday 1 and Hoffer Q, etc., along with that, we also feed into what's the age, gender, and so many parameters.
No, which IOL formulae in today's world?
Kane, sir. Kane formula and Hill RPF are AI assisted.
How exactly the AI is giving a better result than the other formula?
So
where exactly AI comes in?
It's just with the additional parameters it takes into account, so that from various data that has been fed into it, and thereby the human error, even by 0.5 diopters can be reduced.
It is the previous experience. People have already fed in more than 30,000 case scenarios, their pre and post-op refraction, all the details. So it is using the previous experience of 30,000 or plus data to refine. It doesn't give you IOL power. It only gives you the correctness or what could be the thing that sometimes it may not suggest anything at all if it does not have that experience. So AI is not everything. Most time it's dumb. It says, I can't comment, okay, like our politicians. Thank you.
Thank you, sir.
Like our politicians.
Our next presenter is from the team at Ropa Balladonas, Dr. Saloni.
Good morning, everyone. At the outset, I would really like to thank the judges for selecting our team for the finals. And my topic is DSEC versus DMEC. And we may be the finalist or creme de la creme of the day, but as junior residents, we all struggled with even the acronyms. So don't worry, I will break it down for you quite literally, because we are talking about component keratoplasty. So this is the basic diagram for you. We moved on from penetrating keratoplasty to component keratoplasty over the turn of the last century, because as we knew that in component keratoplasty, what gets affected is the globe integrity, and with sutures comes a lot of astigmatism, and even with trivial trauma, patient could have graft dehiscence. So there was a general consensus that we need to go ahead and devise component keratoplasty. So as we know, in DSEC, we take the stroma, Descemet's membrane, and the endothelium, and in the DMEC, just look at the graft. It's hardly 10 to 20 microns, and that is what we transplant in DMEC. So we owe it to these guys for developing the newer techniques. What is your ideal candidate? That is the first question of the debate. So as we know, we are transplanting the endothelium, and the dystrophies, pseudophakic decompensation, iridocorneal endothelium syndrome are the indications. But look at these scenarios. It is a heavy slide to take in, but the general, what picture it is giving you. If you look closely, it is not just a decompensation. You have associated aphakia, aniridia, hypotony. So in complex situations, you tend to choose a surgery that is DSEC. As we can choose the donor parameters matter a lot too, because it has to be an optical grade cornea. So let us get into the surgery. We need the microkeratome for the preparation of the DSEC lenticule, and I won't get into all the details, but let me just tell you the main part of the surgery, how do we identify the orientation. For DSEC lenticule, we have thankfully the double ring sign, the acute angle bevel sign. Double ring sign, you don't need the AIOCT, but on the AIOCT you can see the acute angle bevel sign to identify your graft. Again, in DMEC, just look at the size of the scroll. As a surgeon, I personally would actually just go with the evidence and see what they say. If we look at the meta-analysis, as far as best visual acuity is concerned, DMEC scores over DSEC in the reviews, and as far as endothelial cell count and the percentage decline over the years is concerned, there was a bias towards DMEC that was seen, so there was no generalized consensus as to which one is better. And finally, graft dislocation is clearly lesser in the DSEC group. So what does it say? Ultimately, even the evidence is not black and white. What prevails is gold clinical, in clinical acumen. You decide based on case-to-case basis what is best for your patient, and that is the way forward. Thank you.
So I only noticed, very good presentation, Saloni.
Thank you.
I was curious that DMEC versus DSEC, is this something that residents would be really looking at in terms of, because yours was more instructional, that these are the indications for DMEC and this is for DSEC. That is sounding like as if you're instructing to them to select the cases. So is it done in residency programs these days? If it is, then great. That's not my question though. My question to you is that it was good to see that you put up the Cochrane review, but the studies were rather old, and subsequent to that there has been some more comparisons of the two techniques. So what about the endothelial cell counts? Do you know what happens to them in each of the techniques?
Ma'am, the fact is the percentage loss over time. Yeah. So it has been studied that over 6 months, like in DSEC, there was about 30% endothelial cell loss after 6 months, and over the years it progresses. And in DMEC, there was a similar number, 25 to 30% cell loss was noted in both DSEC and DMEC. But some of the studies that were seen earlier, it was seen that either two eyes of the same patient were taken. So there were some biases inherent in the study models. So even in the reviews that I looked up, there were no definitive consensus on which fares better. So
no, there are definitive consensus on which fares better. But yeah, there's still, I agree with you that it's not, you don't have a conclusive meta-analysis talking about the endothelial cell count. That way you're right. Okay, thank you.
Thank you, ma'am.
Our next presenter is from the team AIMS Patna, Dr. Kopal Srivastav.
Good morning, class. In yesterday's class, we had studied about SMILE and LASIK. Now today we will be going to discuss when and what to choose in this surgery. So it is a great dilemma for the surgeon that whether the patient is suitable for this surgery or which surgery is best for which patients. So first of all, I would like to briefly summarize the yesterday's class that who is the ideal candidate for LASIK surgery. That age is greater than 21 years with a patient of stable refractive error. There was no history of systemic and autoimmune disease, with a patient properly counseled. And the indications for LASIK surgery include all three: myopia, hyperopia, as well as astigmatism. And for the SMILE surgery, it includes myopia and astigmatism. So what are the contraindications for all these surgeries? It includes all three contraindications, that is ocular, systemic, and drugs. Ocular contraindication, the most important ones are unstable refraction, severe dry eye, and progressive corneal ectasia, while the systemic one includes pregnancy, lactating women, and autoimmune disease. These are the various drugs which are also contraindicated for the surgeries. The cutoff parameters, the most important one is residual stromal bed thickness, which should be greater than 300, and percentage tissue alteration, which should be less than 40%. And Monellin formula is used for calculating the ablation depth. So how should we approach a patient? First of all, patient presenting to our OPD, we should look for the profession of the patient, whether it is there was a history of contact sport, armed forces, or boxers. If all these three history are present, the SMILE is preferred for these conditions. Refractive workup is required for all the patients, and the patient with low myopia and high astigmatism, LASIK is preferred, as low myopia small lenticule is formed, which is further complicating the SMILE surgery. And a patient with low pre-existing higher order aberration, SMILE is preferred. In patient with deep eyes, narrow palpebral fissure, LASIK is preferred than over SMILE, as SMILE can lead to more suction losses in intraoperative period. On anterior segment examination, if we see that there was a mild dry eye disease, weak corneal biomechanics, and larger pupil, SMILE is preferred over LASIK in these conditions. Posterior segment examination, if we see the history of glaucoma or peripheral retinal degeneration, SMILE is preferred over LASIK. So we had studied all the approaches. Now we will like to summarize this condition, then when should we prefer LASIK and when should we prefer SMILE. LASIK is preferred in the condition of myopia, hyperopia, and as well as astigmatism, while SMILE is preferred in the condition of dry eye disease, fewer higher order aberration with better mechanical stability. So after studying these scenarios, I will like to solve these few questions. The 21-year-old female presenting to our OPD with a high astigmatism in both eye. What is the ideal surgery for this patient? Yes, LASIK is the ideal surgery for this patient. A 23-year-old female presenting to our OPD with a myopia in both eyes and shows dry eye in both eye in Shermer's. So what is the ideal surgery for this condition? SMILE is the ideal surgery for this condition. And a 25-year-old male footballer by profession, what is the ideal surgery for this condition? SMILE is the ideal surgery for this condition, as flap can lead to weaker biocorneal mechanics. So after studying all the points, now I just like to summarize my class as LASIK is preferred in the condition of narrow palpebral fissure, low myopia, high astigmatism, as well as hyperopia, and SMILE is preferred in the condition where weak corneal biomechanics, dry eye, higher order aberration, and contact sport profession. Thank you.
Thank you.
Thank you, Kopal. Nice presentation, and you selected some very different topic actually compared to what we were seeing since yesterday. So my question to you is that, so I have a patient who is 39 years old, wants to get rid of glasses, and has -3 and -4 refractive error, and biomechanics, everything is good. Which technique would you prefer?
Please repeat the question.
39-year-old wants to get rid of glasses, -3 and -4 refractive error. So other parameters are fine. Doesn't have dry eye, and corneal biomechanics are okay. The topography is fine. So which technique can I offer to this patient?
Ma'am, ideally it is we should go for near vision also. If a patient is presbyopic also, we can go for presbyopic correction. For that we can...
So 39-year-old pre-presbyopic, so currently doesn't have presbyopia. My question obviously to you is that would you prefer LASIK or SMILE, and why?
We can go for both surgery, but I will prefer SMILE for this condition.
Why? I'm not saying you're right, but...
Ma'am, because the SMILE includes, as there is a good corneal biomechanics parameters and stable refraction, we can go for SMILE for this condition.
So why not LASIK?
We can go, ma'am, but...
okay, which one would you prefer?
SMILE.
Why?
She doesn't know why.
You don't
That's
know
why
why.
she is going
You
round
just
and
like
round
SMILE.
and round.
Okay, fine. I'm sure the company will be very happy. All right, yeah, thank you.
Smiling, that's all.
So next speaker is from team CFS Retina, Dr. Bhanupriya, right?
Yes, sir.
Please go ahead.
A very good morning to all of you. In this session, I will be talking something about management of VRVO. So out of these common vascular diseases of retina like diabetic retinopathy, vascular blocks of retina, arterial block, venous block, VRVO is somewhat a milder disease. It's the obstruction of branch of retinal vein at an arteriovenous crossing. So it's the second leading cause of vision loss after diabetic retinopathy. Patients who have aged more than 60 years are at risk associated with some systemic risk factor like hypertension, hyperlipidemia, diabetes mellitus, high body mass index and smoking. But if you have a patient of younger age, less than 50 years of age, you need to rule out these thrombophilic disorders, especially hyperhomocystinemia. Sorry. So patient can present symptomatic or asymptomatic depending upon the macular involvement, or sometimes it can be an incidental finding also. So BRVO is divided into two forms depending on which venous branch is affected. It's a major VRVO or macular VRVO. It's further divided into ischemic and non-ischemic. As ischemic one, we know it can go into complications. So ischemic is defined as if on FFA you have more than 5 disc diameter of non-perfusion area. Causes of vision loss in VRVO is first is macular edema, second is macular ischemia, and third is neovascularization. Earlier, the standard of care was the laser treatment as depicted by the Vivos study, which concluded that grid laser treatment was recommended for the macular edema if vision is less than 612, and sectoral laser was done only if neovascularization is present. After 2009, what came is just we saw dramatic change when steroids and anti-VEGF became the king of the macular edema treatment. So, and FDA approved anti-VEGFs were ranibizumab, aflibercept, and faricimab. So, if you have a patient of BRVO, apart from monitoring the visual acuity, fundus evaluation, and OCT, our aim is to identify the ischemia, identify the sight-threatening complication, which is neovascularization, and must do a workup for the systemic disease. So you have a patient, you see that is non-ischemic BRVO, vision is more than 612, you can wait for a couple of weeks. If vision is less than 612, macular edema is present, go for anti-VEGF. If there is ischemic VRVO, macular ischemia is present but OCTs show macular edema, go for anti-VEGF, and neovascularization present, sectoral laser work. So this is a patient of 1 who came with the superior temporal VRVO on FFA. A branch of vein is occluded in the early phase, and you can see the leakage in the late phases. On OCT, perfused macular edema is present, anti-VEGF is the treatment of choice. Patient 2, macular VRVO, on FFA you can see the leakage is within the macular area, and on OCT macular edema is present, go for anti-VEGF. In patient 3, After multiple doses of anti-VEGFs, patient had persistent edema. So what to do? FFA is done, leakage area is seen, and CNP areas were there. So sectoral laser was done as a definitive treatment. So take home message is VRVO is not a very scary disease. Just identify the risk factor and treat well. Thank you so much.
Yeah, well done, Dr. Bhanupriya. Just a question, a simple question. How does hypertension actually predispose to BRVO? What is the exact mechanism?
Sir, in hypertension, we have so there is a abnormality in the vessel. So vessel will constrict, and there is changes in the there is arteriosclerosis. So artery and venous are within the same adventitia. So when artery is sclerosed, so when artery is sclerosed, it actually the vein is collapsing because it is a closed space among the adventitia. Artery and vein both are there. Artery is being sclerosis is there.
Normally
and
artery is above, vein is above.
Sir?
Artery is above or vein is above normally? What is crossing over the other?
Vein is below and artery is above.
Okay.
So artery is sclerosed, so it is pressing the vein and vein is being blocked.
Okay. So, and the second thing is in an young patient, like a 32-year-old male comes with BRVO.
Yes, sir.
I mean, what exactly simple 3-4 investigations that you check or you see? I mean, that's not the usual age, right? So then probably something else should be done. So what exactly be the top 3 things you see in a 32-year-old BRVO?
Yes, that's a very good question. So I have explained that if a patient is less than 50 years of age, so sir's question was 30 years. So your patient is 30 years of age, you need to do a proper systemic examination. First I will check the BP of the patient, then I will check for the second was the most important was the hyperhomocystinemia. I will order hyperhomocystinemia, and if I see the patient is higher body mass in this patient, I will try to rule out some carotid Doppler also if I
told you top 3, when you said very good question, that means that you are probably trying to buy time. So top 3 things that you do in a 30-year-old. You are again going back to your PPT.
Okay, sir. So sir, it's so check the hypertension, CBC, and hyperhomocystinemia.
Okay, good, good.
Thank you so much for patient listening.
Finished within time. This is actually good. She answered. Okay, we are compiling the marks very in the shortest of the time. There are only 10 talks. So till Dr. Somshila comes with the final result, just a few. I mean, obviously everybody was excellent given the time and the situation. Still, that means you have a very good future. That is the first statement. With little training, with little more, upgradation, you can really, storm the stage. And Dr. Namrata will have a tough time trying to pick up people for her talks, and we all will be retired very soon. Right? So simple things. Again, same mistakes happen. Everything. The PowerPoint has what is called custom animation. No, when you press the button, something comes up. The next one. So don't put the whole thing on the slide. You are reading from the top. We are reading from the bottom. So a very busy, crowded slides are not good. If there is so much, then you let things come sequentially, one after the other, so that you don't really distract the audience. Don't use PowerPoint to distract people. You have a lot of animations and GIFs and all those irritating things and downloaded photographs. Please, very importantly, everybody can make a PPT. You can download it from a slide share. You can do a PPT within half an hour. Your artificial intelligence can do. So there's nothing great about adding those things in a scholarly discussion like that. At this stage of life, you don't really need that. Okay, use only these things to highlight something, not to irritate or to distract the audience. That is for an younger crowd. And most importantly, you have to have an eye contact. Okay, basically you are looking into your slides and only lifting. So basically you need to speak to the audience. So you need to come with the rehearsal. The slide should be just an aid to make you remember what you're going to speak. But that should be telegraphic. Don't put the entire sentences. Basically speak as if you are, doing a conversation. That is something very important. And original photographs and videos if possible. Obviously everybody will not have access to original photographs and videos, right? You can always download. We can come to know by the quality, okay, by the color of the iris, what photo, what video this is. So where do you get you can always see, that is the homework that you do. For example, Dr. Somshila is doing a particular surgery. That is my topic as a student. I will request her, can I borrow her surgery? Please put your credits. Acknowledge the, contribution for that video courtesy, Dr. Somshila Murthy. So that's the way it is. It should never, otherwise even if it is internet, please you have to acknowledge the source. Please acknowledge the source unless it is your own. And original photographs is always very important. And you can always come off the podium. Nobody asks for a collar mic. I was just looking for who are those people who will be asking for a collar mic. Everybody is stuck behind the podium. I'm not necessary that you have to really come out all the time, but to add some, X factor, some animated talk, some kind of a histrionics to stand out from the rest. When everybody was presenting in a very typical seminar fashion, okay, student seminar fashion, you could have probably done something different. Okay, that would have probably carried some marks. And finally, the props. Don't use the props for the sake of props. It should actually try to, make something to understand easy. That is the whole idea. And it should also be innovative. For example, let me just quote one example. One of my students did that. There was actually a topic on dissect and demec, what was actually it was there, no? So she had actually got one watermelon carved out. So that green part, the white part, the red part, she was showing this is different layers of cornea. She was using that carved out thing. Okay, something very innovative. When that was being shown, the judges were served watermelon juice. She said, I didn't want to waste the pulp. Okay, this is the kind of, thinking that you need to do. Not just for the sake of props. And everybody can bring a chart and show. That doesn't make sense. When you actually have a PowerPoint, if you're just giving a talk without a PowerPoint, then that should help. Not when you have an audiovisual, presentation, the props will be just you are thrusting upon the people without the actual need for it. So try to understand these things, but otherwise your diction, your oratory, and the very fact that you have made it to the final itself says that you have it in you, you have that streak. Please nurture that and try to go to a conference, sit and see how people talk. If they talk well, learn from it. If they don't talk well, then also learn from it. Okay, you both ways, good talks and bad talks, both will make you better. Okay, how to do things, how not to do things. Okay, and wish you all the best for the rest of your life behind this podium. Okay, and welcome
Thank
to
you, sir.
This side of the podium.
For me, Dr. Anu, thank you everyone for participating in this huge number. Each time we do this program, the number count goes up. This time it was 33 entries. 22 could make to the venue, and out of that 5 could make to the finale. And sorry, Dr. Birla, your mentee left you in between, or else you could have also participated here. So all these points you should take forward, because this TOT, we keep on doing this 3 to 4 times a year. So what I would suggest, next time when you come prepared, then remember what Krishna Prasad sir is telling you or Dr. Somshila ma'am is telling you. And those who may not get the hours today, don't worry, we are doing same program 1 month later at DOS midterm conference. You can participate there, okay? And we'll keep on doing this till you people become good teachers for future, right? So I hope you are ready with the name, sir. Okay. So for me, you all were awesome, especially those candidates who prepared the new talks within a
So we
time
have
of.
it in Delhi also, no? On a bigger scale, TOT. The next conference in APAO also.
APAO, we don't know. We may not get a space because of the
But if it is there,
session
please
crunch.
tell your juniors and your friends, to participate.
We'll try to
to
do
apply
it,
before
and
that.
we'll request our chairperson scientific committee to give us a hall. But anyway, You all were awesome, and especially those new speakers. Within 12 hours, you prepared such nice talks. That is awesome. And but there is always a scope of improvement. Okay, so next time we'll do much better. Abhidar?
Myself and Dr. Somshila Murthy have come out with the results. Anyway, it's customary to say that all were equally did well, and it was a tough job for us. Okay, I'll cut that.
Tough job. It was really tough.
So there are
small
5 teams.
yeah.
We have to select the top 3, but doesn't mean that the 4th and 5th team did really anything less. Okay, everyone deserves the prize, but since we have only 3 set of medals, we are forced to announce the results this way. So the 3rd place goes to the team CSF Retina, Dr. Shweta Singh and Dr. Bhanupriya. You can please come out to this side so that we can have the medal presentation at once for all of you. नहीं सबको इधर खड़ा देंगे. Namrata just call Namrata. I told her. Huh?
She is in between a quiz.
Okay, then छोड़ो. Okay, then fine. And the 2nd place goes to team the Preceptor Queens, Dr. Radhika Agarwal and Dr. Nikita Ahuja. I think you all can clap, please. And the 1st place goes to team Moria's Master Blasters, Dr. Ruju and Dr. Farnaz.
Bronze medal देना पहले. So we have certificates for you, but we'll give you a little bit later after checking your spelling, everything, right? Dr. Anu will ensure that you people get the certificate. Now we will be giving you the medals. I request judges to come forward.
So 3rd team CFS Retina, Shweta and Dr. Bhanupriya.
Mentor is not there. So mentor वाला medal मैं ले लेता हूँ, श्वेता. Thank you all. With this, we come to conclusion of this wonderful session of TOT, and I hope I'll see you all again in DOS midterm, 23rd, 24th November, Hotel Ashok, New Delhi. Okay, if you want to participate, you can message me directly. I'll include your team in that session. And for certificates, Dr. Anu will give it to you. You can collect. कहाँ से? I think Lalit sir is here, so we can. Lalit sir, आपका medal है pending. Team CFS, come forward. Team CFS.